Now coming to gingival recession. Okay, so as I told you, gingival recession is the apical migration of gingival margin below the level of CG. Okay, so gingival margin, the patient is going to main complaint will be sensitivity. Fine. Okay, now we are going to talk about very important aspect, the etiology of gingival recession. How come this gingival recession takes place? Fine. So the first and foremost will be age. Okay, so what happens as the age increases? Okay, as the age increases, there's going to be repeated minor trauma to the gingiva, which is going to it's just happening over a period of years. Okay, repeated minor trauma, which is going to happen over a period of years, that is going to result in recession. So age, invariably, whether you're having disease or habits or any pathological situations, you are going to get recession because of the repeated minor trauma which is going to take place. Fine. So the next one what we are going to see is the developmental or anatomical factors. So the developmental or anatomical factors is nothing but it totally depends upon the tooth and not because of any external factors like plaque or calculus or habits, nothing like that. Okay, so what are the things like that is, the first one is abnormal tooth space, aberrant path of eruption. The tooth erupts not normally, like it's going to move buccally or palatally placed. Inadequate space to erupt. Because of the inadequate space to erupt, what happens? There is going to be buccally placement of the tooth, and also if the eruption is good and the space is good, what if there is no, or the position of the tooth in the arch is displaced? If there is good space, good eruption, but the position is abnormal, so inadequate or abnormal position. Fenestration and dehiscence. Fenestration, it is nothing but it is a window shaped defect which the where the bone defect does not communicate with the marginal aspect of the bone. The marginal bone is intact in fenestration, whereas in dehiscence the marginal bone is completely involved. Okay, so fenestration and dehiscence. Okay, or any abnormal root morphology. Okay, so these are all the few developmental and anatomical factors causing recession. Okay, abnormal tooth space, path of eruption, inadequate or if the position of the tooth is not normal, fenestration and dehiscence, abnormal root morphology. Okay, so the next one what we are going to see is the pathological factors. So as of now we have seen about age and anatomical and developmental factors. Sorry, age, anatomical and developmental factors, and now we are going to talk about pathological factors. Okay, see, the pathological factors, as the name implies, it denotes inflammatory diseases, periodontitis, inadequate or less space in the vestibule, inadequate vestibular depth, abnormal muscle pull. What do you mean by that? Simple. Frenum, eye frenal attachment. What is the treatment? Frenectomy. Very good. So periodontitis, inadequate vestibular depth, abnormal muscle pull, or any friction from the soft tissues, that is nothing but gingival ablation. So these are all the few pathological aspects because of which recession takes place. Next one will be the local factors. Local factors will be block, calculus, or any overhanging restorations. Okay, so as of now we have seen about age, repeated minor trauma, developmental anatomical factors, pathological factors, local factors. The next one what you are going to see is the any deleterious habits. Okay, any deleterious habits like pencil biting, nail biting, or any pin biting in case of tailors, right? So these are all the few deleterious habits which might lead to recession. Faulty toothbrushing. Okay, so most commonly a young patient, say for example 20-25 year old patient comes to you with isolated gingival recession, the majority 90% of the times it will be because of faulty toothbrushing. Okay, so identify the cause, tell them what to do. There will be creeping attachment. What is creeping attachment? The post-operative coronal migration of gingiva after treatment, right? That is why I'm calling it as post-operatively. Okay, fine, very good. And also some miscellaneous like piercings, extraoral intraoral piercings, or orthodontic bands, these might also cause recession. Okay, so we have talked about age, we have talked about anatomical developmental factors, we have talked about pathological factors, local factors, deleterious habits, and miscellaneous. So these are all the few etiology of gingival recession which is very very important for you to get to an idea of how to treat a patient with gingival recession. Just because a patient comes with gingival recession, you cannot directly go and tell them, no, you have to do laterally position flap, you have to do free gingival graft, connective tissue graft. No, you cannot tell that. Okay, you should know exactly the cause and then you have to treat them. Fine, excellent. Now moving on to the classification. So this is the most commonly used classification which was given by P.D. Miller 1985. Okay, so this classification is what we use generally. Okay, so the first one is class 1. So this classification generally was given based on the marginal tissue recession and the presence or absence of interdental bone loss or soft tissue loss. Okay, so in class 1 there is going to be marginal tissue recession. As you can see here, the marginal tissues have gone down below the level of CEJ. And if I take a look at radiograph, there is no interdental bone loss. And for these kind of patients, there will be 100% possibility of root coverage, which means it's going to be good or excellent prognosis. Class 2, marginal tissue recession does not or extend up to the level of mucogingival junction. Here in class 1, marginal tissue recession does not extend to the mucogingival junction, whereas in class 2, it might extend to the mucogingival junction or might not extend to the mucogingival junction. Okay, but again, invariably there is not going to be any kind of interdental bone loss radiographically, which means again for these patients the root coverage results is going to be excellent or good. 100% root coverage is possible for these patients. Class 3 is patients who are having marginal tissue recession extending beyond the mucogingival junction, and also there is presence of interdental bone loss and soft tissue loss clinically and radiographically. So for these patients we can expect 50% of root coverage when we take up for treatment. Class 4 is the exact into two versions of class 3. There is going to be excessive soft tissue loss, excessive bone loss, tooth malposition, tooth collapse, tooth mobility. All those things will come under class 4. And in these patients in class 4, the root coverage is contraindicated. To be specific, you should not do a root coverage procedure for class 4 patient. Okay, so 1, 2, 3, 4 is given by PD Miller 1985. It is generally based on soft tissue recession. There are a few drawbacks of Miller's classification. So Miller, he didn't talk about the lingual recession. He just talks about the buccal recession, but doesn't talk about the lingual or the palatal recession. Two is, you look at class 3 and class 4, it is very difficult to find whether it is class 3 or class 4. So he didn't give an exact distinguishing feature between class 3 and class 4. See, I'll tell you a scenario. You just tell me what classification of recession it will come. Patient having recession, marginal tissue recession that does not extend to the mucogingival junction, and there is intrarenal bone loss. You cannot classify them. You cannot classify them. So that is also one of the drawback. It didn't specify the exact scenario when it should be class 1, class 2, class 3, class 4. Just based on the mucogingival junction, he gave the entire classification. But this is overall followed universal classification for gingival recession. Fine. It's given by PD Miller 1985. And then Mahajan, okay, Mahajan, he modified the Miller's classification. Okay, so class 1 recession not extending to the mucogingival junction, class 2 recession extending to the mucogingival junction, class 3 is recession with bone or soft tissue loss in the internal area up to cervical third and or malposition. 4 is recession with severe bone loss and severe soft tissue loss with greater than cervical 1/3 of the root surface. Okay, so there is going to be bone loss greater than the cervical 1/3 of the root surface, and also there's going to be severe malpositioning of the tooth. Okay, this was the classification which was given by Magajan, which is a modification of Miller, slight modification. Fine. Now the recent classification of gingival recession was given by Cairo et al. Okay, so this classification, it just tells like RT1, RT2, RT3. Okay, it talks about the interproximal attachment loss as well as the buccal attachment loss. Okay, so in RT1, that is in recession type 1, there is going to be no interproximal attachment loss, and the interproximal CEJ is not detectable at both mesial and distal aspects, which means it exactly corresponds to Miller's class 1 and 2. In Miller's class 1 and 2, there is not going to be any interdental soft tissue loss or bone loss. There is going to be only marginal tissue recession that does not extend to the mucogingival junction. The same way, you see there is no interproximal attachment loss and the CJ is not seen mesially and distally, right? Now RT2 is the gingival recession which is associated with a loss of interproximal attachment area, but the interproximal attachment loss is less or equal to the buccal attachment loss. Okay, architecture, positive, negative, and flat. And recession type 3 is exactly the opposite of 2. The interproximal attachment loss is more than the buccal attachment loss. This is RT3. This is the recent classification of recession which was given by Cairo et al. RT1, RT2 and RT3. Fine.